Greetings, everybody. As promised, I'm going to produce this slideshow to finish up the system of blood and blood products and blood activities. Hemostasis. We already talked about hemostasis in class, started in on it anyway, and I mentioned to you that there were, I'm going to start a laser pointer here, mentioned to you that hemostasis, hemo means blood, stasis means to be still. So blood be still. Of course, the clotting of blood. Three factors here. We've already gone through vascular spasm, right? That's stimulated by cutting and breaking the vessel. Smooth muscle contraction helps to reduce the amount of blood loss through that tube, right? You're just taking a tube and you're squeezing it down like you would with a garden hose. You're just trying to get less stuff out of it. It's not a perfect system, but it's a good start. Here's what happens. You get a slice. That's a pretty nasty looking knife. But you get a slice in there, goes through all of the three layers of the artery, in this case, or vein, whatever you're cutting. There are three layers, and we'll get to that when we talk about the vascular system, the three layers of these vessels. Well, he's gone all through, all three, into the blood supply itself. That means that it's exposed. There's a hole. And so things start leaking out. One of the things is platelets start leaking out, and they become activated because they come in contact with collagen. Once they become activated, they become sticky. They stick to themselves, they stick to each other, they stick to red blood cells, they stick to everything that's coming out that hole, everything that they can possibly glom together. Third part that we got to talk about is the formation of fibrin, which is the insoluble part of fibrinogen, and it creates a net and catches more things in there and really ends the bleeding process. Right, so here's platelet plug, first vascular spasm, platelet plug, and remember these events are all happening simultaneously. But they take time, right? So platelet plug is pretty quick. Vascular spasm is very quick, mediated by the sympathetic nervous system. So it's very fast. Platelet plugs are a little bit slower because it takes a little while for enough platelets to leak out to become active to actually form a platelet plug. And then slowest of all is this last part, blood coagulation. This is what you think of as a blood clot. But a blood clot really is the combination of fibrin strands, the capture of, as you see in the picture, capture of red blood cells and platelets, white blood cells, and structural proteins that are leaking, and they get caught in this web, this net-like fibrin meshwork. All right, here's the three things. We've already been through that. Let's get really into coagulation itself. So the coagulation mechanism is composed of two separate paths. There is a common pathway, and in the end, remember this, in the end, it's the formation of fibrin that is the essential quality of coagulation, right? Insoluble fibrin threads. But remember, fibrin starts as fibrinogen, and this OGEN means it is an inactive form of fibrin. We're going to see this suffix many times in the future. So, the first of the mechanisms that we'll talk about is called the extrinsic clotting mechanism, or extrinsic coagulation mechanism. This begins with damage outside of the blood vessels. That means you have to damage, like the slide that had the knife slicing in. That's how this mechanism gets going. When tissues are damaged in that way from the outside, they release this factor, this clotting factor, and you're going to see there's going to be a whole table listing out all of these clotting factors, and they all are called factor something. Factor 1 is fibrin, right? That's the most important thing. We would say, okay, well, that's number 1. Yep, it is number 1, factor 1. Then we'll go back and forth. Damaged blood vessels, damaged tissues release this compound. It's called tissue thromboplastin, or it's also called factor 3. This is factor 3. or it's called tissue factor. Sometimes you'll see it just listed as tissue factor, TF. Nevertheless, damaged tissues release that. Well, that immediately begins a quick cascade. This is a very fast way to establish a clot. Factor 3, and we're going to see the outline of this in the next few slides. But once factor 3 is released, it quickly results in the activation or the conversion of fibrinogen to fibrin. The thing that converts fibrinogen into fibrin is this compound here called thrombin. And so we say it's a cascade mechanism. One thing gets activated, that activates the next thing in the chain, that activates the next thing in the chain, and the next, and so on. And we usually refer to the coagulation mechanism as a positive feedback mechanism because once you get things activated, they tend to activate the next and the next and the next and the next. Now, this can't go on forever. You should already understand that you can't have a positive feedback mechanism without end. You will clot everything, and then you'll just be a big walking clot, and people who are walking clots are dead. So that's not going to work. So there are mechanisms already going that will reduce the intensity of this effect. But for all intents and purposes at this point, this is a positive feedback mechanism. So this is the extrinsic mechanism. The other mechanism is the intrinsic clotting mechanism. This does not require external tissue damage. This can start, say, for example, if you have sepsis, if you have a blood-borne infection, that can result in a clotting process, an intrinsic clotting process. Internal damage to the endothelial lining of blood vessels can also lead to the initiation of an intrinsic clotting mechanism. We say you don't have to have necessarily tissue damage. It doesn't mean that the tissue is in good shape necessarily. The intrinsic mechanism is also the way in which, say, for example, a myocardial infarct can get going. If you have a cholesterol plaque building up inside the inside of arteries that are feeding your heart, for example, that can result in a blood clot, and that blood clot starts through the intrinsic mechanism. So I'm saying the tissue itself doesn't have to be damaged extrinsically, but it's usually not in very good shape. But it doesn't have to be. As I said, a blood infection can cause this. When this pathway is activated, it is triggered by this stuff, factor 12. So factor 12 is already inside your blood. It's called Hageman factor as well, so you'll see those terms. Factor 12. And factor 12 activates factor 11, which activates factor 9. We won't get into all the deep details. You'll see it in the pictures, but I don't expect you to memorize all of the path. Suffice to say, the intrinsic clotting mechanism is a longer pathway and takes longer to activate a fibrin clot. So it's a lengthier, longer pathway, but to the same end result. And let's take a look at that. Right, so this is a nice table that compares the two, right? Extrinsic means you have to have extrinsic damage. That means you have to have damage from the outside. Doesn't mean you have to be cut by a knife. You could fall down. You could bump into a table where you create damage to the outside of the blood vessel. It doesn't have to be that your skin is damaged, but the vessel has to be damaged. Tissue thromboplastin, that is also called factor 3, or sometimes just tissue factor. I'm just letting you know, you'll see that. That gets the process going. But now look here. Once you get the trigger and the initiation going, you get prothrombin activator going, prothrombin activator. Prothrombin activator activates prothrombin, and it converts prothrombin to thrombin. And thrombin is the thing that converts fibrinogen to fibrin. Now, you might like to think that you wish this were called thrombinogen. I'm sorry, I don't know who named these things, but they didn't call it thrombinogen. They called it prothrombin. Thrombin converts fibrinogen to fibrin. Fibrin is the stuff that bonds together, that gets sticky, that forms the mesh, the web. Over here, intrinsic, you have to have it contacting a foreign surface. That would be like an infection, an internal infection in your blood. Easiest way to think about it. That's not the only initiation, but that's an easy way to think about it. Once that gets going, Hageman factor, factor 12, gets involved, and it starts this chain reaction, this cascade mechanism, eventually resulting in the same thing. Prothrombin activator activates prothrombin to thrombin. Thrombin converts fibrinogen to fibrin. You're off to the races. Let's look at that. So here it is graphically, right? Here's the intrinsic pathway. Here's the extrinsic. Let's start with extrinsic. Extrinsic first. Damaged perivascular tissues. That means they have to be damaged from the outside the blood vessel. That releases tissue factor or factor 3. Once that happens, factor 3 and factor 7 combine together, and they form a product along with calcium. And we're going to see in the next slide, this little bit down here, this slide will continue down there. You'll see we'll get into the common pathway. So we have the extrinsic pathway, the intrinsic pathway. They both lead to the common pathway that results in fibrin formation. I want to emphasize that point. Let's go to intrinsic pathway. Intrinsic, we have some sort of internal damage, internal event, internal thing that results in the release of factor 12. Remember, that's also called Hageman factor. That activates factor 11. Factor 11 activates factor 9. Factor 9 activates with some other things, activates factor 8. Again, you don't have to know all these things. I would like you to know what the initiation is, what the first thing in the steps toward this endpoint are. So Hageman factor, factor 12 over here, tissue factor, TF, factor 3, tissue thromboplastin, goes by all those names, combines with factor 7. Let's see where the common pathway, where these both become common. They become common at this point. Factor 10. Factor 10 is the kicker. That's where the extrinsic and intrinsic pathways join forces or join together or end up in the same place. Factor 10 activates the prothrombin activator. Prothrombin activator once it's active. And so these always have inactive and active forms. Once factor 10 is active, it activates prothrombin activator, which converts prothrombin to thrombin. Prothrombin is factor 2. Great. What's the next one in line? Factor 1. Factor 1 is fibrinogen. Factor 1, thrombin converts fibrinogen to fibrin. One final thing in this whole step. You have a clot. You have a web network of fibrin, white blood cells, red blood cells, platelets. They're all stuck in this network, this mesh. One final thing, one final step is factor 13. Yes, factor 13. Factor 13 stabilizes that mesh, brings it together, condenses it into a nice solid clot, what we would refer to as a clot at that point. So one more time, let's back up. Here's the extrinsic pathway. Starts, got to have damage, external damage to the blood vessel itself. As I said, it doesn't have to be a cut from the outside. The skin doesn't have to be damaged. The damage to the blood vessel could happen from the inside. Say for a broken bone that doesn't pierce the skin, you're still going to tear up some blood vessels. Well, that is extrinsic damage. Those blood vessels are broken. They release factor 3. Factor 3, factor 7 join together. In fact, you could think of extrinsic pathway. Factor 3 and factor 7, if you add 3 and 7, you get 10. Yes, that's the thing that they activate is factor 10. Over here, intrinsic, you have to have damage to the inside of the blood vessel, but damage that damage, I would say in quotes, you can have damage to the endothelial lining. You can have bacterial or viral infection that can lead to this pathway. Hageman factor, factor 12, begins the whole process. Eventually you get down to the common pathway, where factor 10, once factor 10 is activated either from intrinsic or extrinsic, the path is clear. On to fibrin, stabilize it with factor 13, boom, there's your clot. Here it is. This is another book that has another pathway. Yep, it looks confusing, but take a moment and take a look at it, right? Extrinsic, remember, tissue damage, that gets factor 3 going. Factor 3 and factor 7 get together and they activate factor 10. You're off to the races to fibrin. Over here, intrinsic, you got to have some sort of internal issue, injury, endothelial lining somehow gets going, which activates Hageman factor or releases Hageman factor, factor 12. That results in eventually factor 10. So on you go. All of the hemophilias, those are blood diseases or clotting diseases where blood does not want to clot or doesn't clot well. All of those are related to the intrinsic clotting mechanism. Factor 11, factor 9, and factor 8. Those are all a part of that. I won't get into the diseases specifically, but they're related to the intrinsic clotting mechanism, either some change in those proteins or a reduction in the amount of those proteins. Here it is. So, what I want you to know of this list. Factor 1, of course. Factor 2, of course. Factor 2 changes fibrinogen into fibrin. Factor 3, or tissue factor, that begins the extrinsic clotting pathway, yes. Calcium ions are necessary all along the path. Oddly enough, it's called factor 4. It's just calcium ions. Now, when these were discovered years ago, they just knew there were things involved in clots, but they didn't know exactly what they were. Come to find out later on, what they were always calling factor 4 just turned out to be calcium ions. I don't care about the rest of this stuff. Factor 10, you should understand that factor 10 is the conversion point of the intrinsic and extrinsic pathways. They both converge on factor 10. Once 10's going, you're on your way into the common pathway and then to develop fibrinogen. Hageman factor gets the intrinsic pathway going, and then factor 13 is fibrin stabilizing. That's just the part that pulls that mesh together. So factor 1, factor 2, factor 3, factor 10, factor 12, and factor 13. Those are the ones that I really want you to understand and know their role in this. All right, so what happens? You get a blood clot, great. You've stopped the bleeding, great. That's what you want, of course. But you can't have it there forever. Well, first thing is, what does a clot do? It retracts and pulls the edges of a broken blood vessel together. It squeezes serum from the clot. Serum is plasma minus the clotting factors. So as things clot, as these proteins that are in your blood glom together and activate other proteins, they get involved in this process and they're removed from plasma. What's left over is something that's similar to plasma, but without the clotting factors. It's called serum. Now, this is what I really want to get into here. Plasmin. Plasmin is another protein that gets activated in a much more slower process. But it is the beginning of its activation is the initiation of a blood clot. So really, you are already initiating the demise of the blood clot eventually when the blood clot forms. Your body knows that it can't stay clotted and it can't stay that way forever, and you can't clot everything. So you're already initiating a process which will result in the dissolution of the blood clot. So plasmin is a protein that's in your blood, produced by your liver, like many of these other factors are. But it is produced in a non-active form, as you might guess. The non-active form is called plasminogen. Plasminogen is converted to plasmin by thrombin. And you're going to say, wait a minute, wait, what? Let me show you something. You're going to say, prothrombin activator changes or converts prothrombin to thrombin. And thrombin is the key thing to form fibrin. Great. Thrombin also acts to convert plasminogen to plasmin. Now, it's a much slower process. It takes a much higher concentration of thrombin for that to occur. But that begins this process of dissolving the clot. But it takes hours to days to weeks for that to happen. So let's move forward again. All right, two definitions here that you need to know. We'll get to the plasmin and plasminogen in the next couple of slides. So a blood clot, overall, a blood clot, what we would call a blood clot, is an appropriate cessation of the flow of blood out of a blood vessel or in a blood vessel. So if you have damage to the blood vessel and you're leaking blood, you want it to stop. That is called a clot, a blood clot. That's good. That's a good thing. You have two other ways of forming a clot that are not good. This one, the first one, a thrombus. A thrombus is an abnormal blood clot that forms in a blood vessel. So the most common one, maybe you've heard of this before, is some people will form clots in their calves, their calf muscles. Say, for example, when you go on a very long airplane flight, they want you to move your feet around, or they want you to pump your ankles. They always say, pump your ankles or pump your feet. The reason for that is to keep blood flowing through the veins in your legs. If blood pools in any part of your body, once it pools, it has a greater tendency to start to coagulate spontaneously. If a blood clot forms in some part of the body, and it shouldn't, so you're sitting on a plane and you're not pumping your ankles and your blood is stagnating, blood flow is stagnating, and it starts to begin clot formation in your calf. Right? That's called a thrombus. And in fact, we often refer to that as a DVT, deep vein thrombosis. So deep vein thrombosis is an abnormal clot that forms in a blood vessel, but that's a clot that stays put. Doesn't go anywhere. Now, that doesn't make it good. That just means it's not going anywhere. still going to block blood flow. If that clot, if that thrombus dislodges from wherever it formed and it starts to flow through a vein, veins always return back to the heart. Usually the clot's going to be small enough to get through the venous system through the heart, and then it will go often, not always, but often goes into the lungs. If that traveling blood clot gets caught in a capillary in the lungs, it is called an embolus. And often, deep vein thromboses can result in pulmonary embolus. A moving clot is not a good thing. It's going to get stuck somewhere. So, you would like blood clots to form where they need to form to stop the flow of blood, and not form where they don't need to be, and certainly not to move around. So, here we go. Now this is a good view of, this is a normal artery, and we're going to talk about the structure of more normal arteries. Normal arteries, any tube in your body has an internal opening, right? That's where things flow through. In this case, it's called a lumen. So your intestines, your esophagus has a lumen, and your stomach has a lumen. Well, so do your blood vessels. They have lumens. They have openings in here. This is where the blood flows. It's supposed to continue to flow. It's not supposed to stop. Here we have an example of a narrowed artery where we get a plaque, usually made of cholesterol and other biochemicals. It starts to build up underneath the endothelial lining, and it begins to make that lumen much smaller. And that makes it much more likely that a thrombus could form there. If that thrombus or embolus stops the flow of blood to certain tissues past the blockage point, that's called an infarction. And an infarct is where the tissues are dying past the stoppage of blood. So a myocardial infarct is occlusion of a blood vessel in the heart, and the tissues beyond that blockage point start to die. When they start to die, we say that's an infarct. They become infarcted. Atherosclerosis is the accumulation of this fatty cholesterol plaque, we say, underneath the endothelial lining, and it begins to close off or narrow the lumen. Okay, so the smooth lining of blood vessels discourages the accumulation of platelets and clotting factor. Right, the endothelial lining is absolutely essential. Let me say it this way, an undamaged endothelial lining is absolutely essential to discourage the formation of a thrombus or embolus. If that's nice and smooth, clean, intact, you have much less likelihood of forming a clot. Generally speaking, fibrin adsorbs to the thrombin, and that prevents the clot from spreading. Usually they stay put. It's occasional that they do break loose, let go, and become an embolus. That's dangerous. This is one of the ways you prevent coagulation in normal tissue. You have a protein called antithrombin, which inhibits thrombin. So if thrombin gets activated, however it got activated, even accidentally, antithrombin will help to inactivate it and discourage the formation of fibrin. Heparin is a molecule that is natural. Basophils and mast cells produce heparin, and that's an anticoagulant. That's one of the reasons why tissues swell up when, say, if you have an allergy to something, you come in contact with that allergen, those tissues will swell up, and there's increased blood flow to the area. It will become red, it will become warm because there's more blood flowing to it, but there's less likelihood of clotting because of this substance called heparin. Heparin is also put into IVs quite often in hospitals to prevent formation of blood clots around an IV site, an access point, a needle in your arm. You don't want things to coagulate when they shouldn't. Right. So these are things that inhibit normal blood clot formation. Won't worry about prostacyclin. There's one other thing that I wanted to point out, that we talked about antithrombin. Let me go back to this slide where I wanted to show you plasmin, this stuff. Let me talk about plasminogen. So you have a substance in your blood that's inactive, plasminogen. Once it becomes active, and it's activated by thrombin, even as thrombin is activating or converting fibrinogen into fibrin, it's also converting plasminogen into plasmin at a much, much slower rate. However, we use this idea in clinical medicine. If you have a stroke, there are two kinds of stroke. You can have a stroke where you have blockage of a blood vessel, an abnormal clot formation in some artery in your brain or blood vessel in the brain, and that will prevent blood flowing from some part of your brain, right? That's called a stroke. And in fact, that kind of stroke is called an ischemic stroke. That's a clot inside a blood vessel. There are other kinds of strokes that are called hemorrhagic strokes. Those are often the rupturing of an aneurysm. An aneurysm is an enlargement and a weakening of an arterial wall. If those break through, if the weakened wall breaks through, blood begins to spill into the brain matter, into the interstitial spaces of the brain itself. That's called a hemorrhagic stroke. The problem here is the distinction between the two. If you're having a stroke, symptoms are going to be similar between the two. So it's imperative that when you access healthcare services, especially when you're in the emergency department, they want to determine as quickly as possible whether you're having a hemorrhagic stroke or an ischemic stroke. If it's an ischemic stroke, we could help you to break up that blood clot so that you had less damage, less ischemia, less infarction to the brain tissue beyond that blood clot. We can do that usually with a CAT scan. A CT scan can help to determine if it's an ischemic stroke. Then we may initiate a therapy where we give you a substance called TPA. TPA is a small t. Let me see if I can draw it on the screen. I might be able to draw it. Yeah, right. So T, and then it's a big P and a big A. Oh no, it's a small a. Well, anyway, doesn't matter. Right, so TPA. TPA stands for tissue plasminogen activator. So if you're having an ischemic stroke, so the bottom line here is, if you're having a stroke that is a blockage of blood flow to some part of your brain, and we can determine that quickly enough, we could administer this product called TPA, tissue plasminogen activator. Guess what plasminogen activator does? It converts plasminogen into plasmin. Plasmin will help to dissolve those fibrin threads and reduce the impact of that clot. That's the idea. But we have to make sure that you're having an ischemic stroke and not a hemorrhagic stroke, so that we can introduce the right kind of treatment to help you to have minimal damage. And it really works, but this treatment has to be initiated within the first few hours. Usually we say for about 4 hours. So that's not a lot of time. So you have to recognize these symptoms initiate the treatment, and it does reduce the overall damage. All right. So I believe that's all I wanted to get into here. Yes. Mm-hmm. Oh, this guy does. Okay. That is it for hemostasis. We're through the coagulation pathways, and I will end this and put the recording on to my YouTube page.